So, so this is another drug class where I think we are challenged with both misconceptions by the public as well as misuse by the prescribing community. So, sedative hypnotics, which include benzodiazepines, drugs such as Ativan, Xanax, Ambien, um, are are used, as you guys are well aware, used pretty regularly in behavioral health work. A couple things that people don't necessarily understand about them, and prescribers don't do, at least in my experience, a terribly good job of explaining the risks and benefits of this class of drugs. These drugs are highly, highly addictive. Tolerance and dependence builds very rapidly, and withdrawal from this class of drugs is among the worst in terms of health danger and medical danger. These are withdrawal from this class of drugs almost always requires hospitalization. And that's probably more my opinion than is stated explicitly in the book. If there was a spectrum of withdrawal in the book, and I understand why there isn't, as we've talked about. And they were asking me to make the list of what are the most what are the most dangerous withdrawals. This one is absolutely at the top of the list. It is a horrendous, horrendous withdrawal, and life-threatening many times. So this is a drug that is not well understood by the public, and much like opioids and prescription opioids, grossly, and this is again not in the book, but from my own experience, grossly misprescribed. And the CDC guidelines for prescription of benzodiazepines, which are very similar to the guidelines for opioids, are they I see it every day. I see it every single day in my clinical experience, and I saw it when I worked in acute care, and I see it continuing now in private practice. People are on high doses for long periods of time without any plan to taper them off, without any end in sight, and they are addicted, and there are consequences. So I thought this video that I share with you here, this show called The Doctors, is not one that I don't think I've ever watched it. Not necessarily that's a bad show, but generally the self-help stuff is not stuff I spent a lot of time on. But I did think that their discussion about benzodiazepines laid it out pretty well, at least in terms of how I feel about it. So a really important class of drugs, one you'll be dealing with if you're doing any kind of clinical work. These Xanax and Ambien and Valium and Ativan are drugs that are used quite a bit in behavioral health work. So so it is a drug that is important for you to know well and understand. And so in the context of the use disorder diagnosis, that all said, the criteria for use disorder is pretty similar to the other classes of drugs, with those nuances to be considered. So as you can read, this follows the general pattern of how we define use disorder among all the classes of drugs. But I wanted to point out this here, a situation that just to be aware of, because I've seen it many times, are where people are taking a drug exactly as prescribed, but the prescription is too much and too long in terms of dosage and duration of the prescription, and people quickly build a tolerance, and can fall into this kind of zone where they don't necessarily feel the kind of some intoxicating effects of the drug, but they are impaired, and yet they're out there driving in operating machinery, but particularly driving people who, and they're not doing it on purpose. They're not necessarily realizing that they're putting themselves and other people in significant danger, but they are impaired in terms of basic cognition and particularly visual, perceptual, motor skills that are required to operate a car safely. They're impaired, but they don't realize it because they're taking their medication. They're 10 milligrams 3 times a day of Ativan. They're taking it as prescribed, and they don't, because they've quickly built a tolerance to it. They don't necessarily feel like they're under the influence, but they absolutely are in many circumstances, and creates a very dangerous situation. Again, just note the verbiage of medical supervision here, and just keep in the back of your mind. Again, this is from me, not from the book, so you just take it as your own consideration. Medical supervision in their contexts, but what I infer is it simply means someone is taking it as prescribed. That does not mean that it is proper medical supervision by any means. Many times it isn't. Doesn't mean it never is, and there are many prescribers who are very thoughtful, go in with a plan, start low and go slow, have a taper plan that is going to, that's not going to extend beyond a couple of months of use of this drug. They're going to push for the individual to seek out non-pharmacological therapies like talk therapy with us. But and that does happen, but many times it doesn't. So just something to remember here when we talk about this medical supervision. So you heard this mentioned in the video clip if you watched it. Um, there are anti-anxiety medications that are basically Buspar is a good example. They are an antidepressant by drug class, but tend to have a an anti-anxiety type of effect, and but they're non-benzodiazepine, and generally non-addictive. You could certainly make a we could certainly have a discussion which is beyond the scope of this course, about potential psychological addiction to antidepressants. But antidepressants are, from a physiological standpoint, are for the most part non-addictive. So that it is possible to have an anti-anxiety pharmacological plan that does not include benzodiazepines. Okay. Remember what I said before, this idea of alcohol and benzos being a really high risk and highly potentially fatal combination, because these are both really suppress the brain and the central nervous system, and can basically cause people to stop breathing. Very significant levels of tolerance and withdrawal, among the worst in terms of withdrawal, as I said before. And these are depressants, by the way. This idea that if someone is having anxiety particularly as anxiety as a byproduct of depression versus versus a generalized anxiety disorder and kind of etiology, benzodiazepines can be really really counterintuitive, because they will cause a depressed mood. They absolutely will, because they are a brain depressant by their chemical nature. And just one more word on suicide. I don't know that necessarily it's fair to say that benzodiazepines make people suicidal. Probably an overstatement. But what is not an overstatement is that these drugs are highly lethal in overdose. And if someone has a stockpile of benzodiazepines, and they're reporting even some suicidal ideation, I would encourage you to think of that in the same fashion you would as someone who's having some passive, some suicidal ideation, but they also have a loaded gun in their home. If someone has a stockpile of benzodiazepines, 90 or so pills in their medicine cabinet, they have a highly lethal method of suiciding at their fingertips. And when I say like a loaded gun, I'm really not exaggerating in terms of if 60, even 30, certainly 90 benzodiazepines are ingested, that is likely going to be a fatal overdose. Again, further evidence, these are not intended to be long-term drugs, for long-term use. Um, Cognitive impairment uh, increases as a side effect with age and can be permanent even after, depending on age. One of the things that I have seen happen, and not necessarily anytime recently, but when I worked in more acute care settings in health plans that acute care treatment, prescribing a benzodiazepine for someone who's having behavior issues related to a neurocognitive disorder will make that behavior markedly worse because it's a disinhibitor. So, like with the other classes of drugs, this can be a really handy list for you to have in terms of, think of this as like a checklist of things to look for with regard to someone being intoxicated on a sedative, hypnotic, analgesic, or benzodiazepine, which is a subset of this. It's also in this particular class of drugs, it can be important to know this list because people may be over medicated and not realize it. And so these are things that that you can look out for in that regard. People can black out and they can pass out from uh, use of this. Sometimes people will. Again, we are very acculturated to think that more is always more, right? So someone may, in the same way, they may see like throwing back a glass of wine with their Ambien as a way to have that sleep inducement work even better. Sometimes people will take, well, I'm extra anxious today, so of course, it would certainly maybe it would make sense to take an extra Xanax. It doesn't work that way. Not only will they not get the the anti-anxiety therapeutic effect they're looking for, but they run the risk of causing a blackout or even a fainting spell or passing out. So as I said, and I can't stress enough, very very dangerous uh, withdrawal when we talk about sedative hypnotics, analgesics, and benzodiazepines as a subset. If you're working with someone whose prescriber appears to have suddenly cut them off from their prescription, and appears that they have are expecting them to go cold turkey, that is a very dangerous situation. They need to get to either a primary doctor or even urgent or emergent care right away. And certainly, if you see any of these symptoms in a context of cessation of whether they've run out, they can't afford it, their doctors cut them off. Um, if they're reporting that to you, first, that's a cause for concern. And certainly, if you're seeing any of this, get them to treatment right away. And if that means go in the emergency room, then so be it. Very, very dangerous withdrawal. So you'll notice here the likelihood of seizures is much higher than it is in alcohol. So again, if there was this kind of spectrum, which there's good reasons to not have it, but if there was a spectrum of withdrawal danger, I might have this class of drug at the top and alcohol right behind it. But and one of the data points for that being the likelihood of seizure is highest for this class of drugs. So remember our general rule of thumb here is that the faster acting a drug is, the more quickly withdrawal tends to set in on an individual. This class of drugs is among the fastest acting, which a short-term prescription to help somebody with panic attacks and a panic disorder, while they're engaging in non-pharmacological treatment and talk therapy. Very efficacious in that circumstance. They work very fast. I've seen these drugs be very effective of bringing someone right out of a panic attack. And that's a good thing. But keep in mind, the flip side of that is withdrawal sets in very quickly and very forcefully.